Good morning, everyone, and welcome back from our short break. I'm Marissa, one of the many people working behind the scenes of the summit today. A quick reminder for anyone to please enter your questions in the chat for our speaker today. She'll be able to address those at the very end of the presentation. And don't worry, we will be sending out the recorded sessions in an email after the event concludes in case you missed anything. So I would now like to introduce Ashley Adkins, a registered nurse and founder of Writing Nursing Crash Courses, to discuss the topic of developing critical nursing skills for critical care scenarios. Everyone give her a warm welcome in the chat.
Hello, everyone. I am so excited. I'm excited to be here and talk about critical thinking. I love critical thinking. I'm a big nursing nerd. So like in nursing school, when we were talking about critical thinking and hemodynamics and all those different things, I was like, sign me up. I love this. So before we kind of get started, I'm going to there we go, briefly introduce myself. So I'm Ashley Adkins. Obviously, I'm a nurse. I got my BSN in 2015. I have my CCRN, which is my critical care registered nurse certification. And then I got my master's in nursing education in 2019. I have two kids. My daughter, she actually turns 5 here shortly in like less than 2 weeks. And then I have a 2.5-year-old boy as well, and a husband in there, because I feel like husbands kind of count, towards something. So, but no, we have 2 kids, 2 dogs, and outside of nursing, we just love living our family life. We have a boat, and we go swimming. We love just doing anything together as a family. But I love nursing education. I've actually been on social media since like 2015 for nursing stuff. And have really transitioned to like the nursing education space over the last couple of years. I love precepting. I love, new nursing students, new grad nurses. I'm not that nurse at work that's like, I don't want a student. I love students. And I currently work in the ICU now. I've been in the ICU for the last 7 years, and I've been a nurse for obviously 8 years. So just really quick, if you guys have any questions for me as we go through, or anything that sparks your interest, you can leave them in the comment box, or you can go over to the question box and ask them there. We'll get to the questions kind of towards the end. And then this is an interactive kind of presentation. So feel free to drop comments, questions. I'm going to be asking some questions throughout this presentation. So please interact with me, so I'm not just sitting here like, hello. Okay. So what we're going to talk about, critical thinking, the what, whys, and hows of critical thinking. We're going to be talking about prioritization, which is a very big component of critical thinking. I'm going to give you a couple pearls. We're going to do some scenario kind of situations and practice some questions at the end that kind of use the information that we're learning throughout this presentation to critically think. And then we'll wrap up with just an open question and answer for you guys to ask me whatever you want. So what is critical thinking? I feel like this looks very nursing school to me, but it's important because we use critical thinking a lot in nursing. So there's 5 steps of critical thinking. The first is observation. So let's think of this as you're a nurse, you're taking care of a patient, you're walking in, and you see your patient is struggling to breathe. So it's the ability to notice, kind of what's going on. We're observing our patient. The next step is analyzing. So gathering all that information, data. Okay, our patient looks to be breathing like 30 times a minute. They're kind of taking shallow breaths. What are their vital signs? Kind of gathering all that data. The next is inference. I'm sorry, I'm not an English major. I'm a nursing major. So if I mispronounce things, just hang on. And this is drawing conclusions. You're like, okay, well, my patient was admitted for pneumonia. They've been on antibiotics. Did they get a chest X-ray this morning? What are we looking at in this situation? And then next is communication. So maybe going to your respiratory therapist. Hey, I've got this patient. He was admitted for pneumonia. He's breathing really quick. These are his vital signs. Do we have any breathing treatments? Should we go notify the provider? Kind of communicating with your team. And then step 5 would be problem solving. What result do we get to? Maybe we give him a breathing treatment. Maybe we kind of sit the patient up in the bed. Maybe we're calling the provider saying, hey, this is a sudden change. So that's the, I think, kind of true component that could be tricky when you're a new nurse, is coming to that conclusion of like, okay, I have all this information. What do I do with it? Okay, so these are some questions I want you guys to answer here in the side. So why do we need critical thinking as nurses, and how do we critically think? You guys can kind of chime in really quick. Critical thinking, I really think, is a big foundational piece of being a nurse. I think it's something that a lot of new nurses struggle with because we are just in information overload when we start off, doing our first nursing job, and we know all this information, but like, what do we do with it? So, why do we need critical thinking? I know there's like hundreds of you on here, so someone wake up and and chat with me. Oops, sorry. But all right, well, I'll just go ahead and answer it. So we need critical thinking for a lot of reasons. We are taking care of sick patients, and we need to be able to look at a situation and decide, do I need to do something about this? Oh, perfect. There we go. We need critical thinking to differentiate care. Yes. Are we going to give this patient a breathing treatment, or are we going to go talk to the provider, or both? Nurses require critical thinking skills to assess complex patient situations, make informed decisions, provide safe and effective care. Yes, all of those things. Critical thinking enables them to analyze data. Love it. We have patients who may have constantly changing health status. We critically think using context clues and our personal knowledge. For safety, yes, we are trying to take care of these patients safely, and we're trying to make good judgment decisions. Maybe a provider orders a medication that's not appropriate for that patient. We are the last line that's going to say, should I give this medication or not? Critical thinking helps us problem solve to figure out what the best intervention is needed for the patient at that exact moment. Yes, these are all wonderful answers. We're going to move on here because I do want to get through everything. Task prioritization. This is a big, big component of critical thinking because when we're looking at multiple scenarios, we need to be able to decide what comes first. So first and foremost, and this is available for download. I have a website, so at the end I'll link all my stuff, but you can download this for free on my website if you want to keep it. We want to address our physiological needs first. These are our ABCs, our unstable vitals. If a patient has a low blood sugar, arrhythmia, stroke symptoms, critical labs, bleeding, like I don't want to say it's obvious, but when you're looking at this, you're going, I need to take care of this right now. Something is a big change. Next, we're going to move to stat orders. These are things that the providers may enter, like your stat meds, stat labs. Maybe they have procedures, like we need to go to a stat head CT. And then your last priorities are going to be everything else. These are your routine assessments, vitals, labs, your general med pass. Maybe the patient has a family concern, or a patient or family has any concerns going on. All of this stuff is important, but in the rank of most importance, we definitely want to address those physiological needs first. All right, critical thinking pearls. So these are kind of my words of wisdom. Vital signs, always ensure accuracy. I know that sounds so like simple and obvious, but I can't tell you how many times a monitor goes off or you get this abnormal vital sign on your patient and nurses are like, oh my gosh, their blood pressure is 210 over 110. And I'm like, okay, well, what was it prior? And then they check it again. Oh, the patient must have been laying on the blood pressure cuff or something like that. So look at the patient. Is this expected for your patient? Is this unexpected? And what are their trends? Next is the body likes to compensate ... until it doesn't. Our body is really good at trying to find that like homeostasis, like trying to keep us even keel. And so our blood pressure is a little low, our heart rate's going to shoot up to try and compensate, but that only lasts so long. So we need to kind of catch our patients in this compensation stage before it turns to decompensation. Next is don't ignore problems. If you walk in and your patient is slumped over and before they were alert and oriented times 4, we're going to address that right here now. Obviously, we have a problem at face. And then sometimes when we try to fix something, we may take away the compensation. And what I mean by this is sometimes patients are compensating for whatever's going on. Maybe they have a fever and their heart rate's really high. So we want to address the problem, the root of the problem, rather than just trying to put Band-Aids on things and covering them up. Some basics. So this is kind of just a quick, almost like a BLS rundown, very, very quick. I know this is a lot of information and we're moving through quickly because I want to get through all of this, but CAB, circulation, airway, breathing. These are our priorities. Always, 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 always. Doesn't matter if your blood sugar is 50. If you're not breathing, we're going to address breathing first. Obviously, a blood sugar of 50 is important, but circulation, airway, breathing, always, always number one of your priorities if you're having a patient struggling with any of these issues. Next, I feel like a lot of times in codes, nurses get really kind of overwhelmed, and that's very normal. It's a critical situation going on. But it's very simple. If your patient does not have a pulse, you're going to do CPR. If your patient has a pulse, but they're not breathing, you're going to help breathe for them by using a bag valve mask, ambu bag. And of course, call for help. And then emergency equipment. I stress this to all of my orientees, especially in the ICU. I know this may be different if you're like working on the floor, but always have a bag valve mask available and suction ready to go. And sometimes like on a med surg floor, this may not be readily available in the room, but you should at least know, where can I get this quickly? And in the ICU, we for sure always have this stuff set up because you never know. Code card. So I put a little picture of a code card on here. I think when you get to your first nursing job, it's really important to kind of familiarize yourself with, one, where are the code cards on your unit? And two, how are they set up? They're all pretty much set up similarly, but equipment may be slightly in different locations, different drawers. So it's important to kind of take a look at it. You have to crack a code card open. It's locked. And so if you have a code on your unit, or maybe you're doing clinicals, after the code, always, ask the nurse, hey, can I like look through this? Or like, can you go through this with me if they have the time to kind of go through it so you can be familiar with it. Couple little things, know how to unlock it, because there's nothing worse than being in a code and you're like trying to yank the drawer and you're like, how do I open this thing up? And it's like, we need the meds now. Know where additional backup supplies are, because sometimes you run out. And then also, I didn't mention this on here, but the code card is plugged into the wall. I have very dramatically ripped the code card out of the wall before, not realizing that it was plugged in, when you're just trying to run with it and get it, to the room quickly. And then last I put on here is identify 2 to 3 roles that you're good at. We're not going to be great at everything when we start off with, and that's okay. Maybe you're really good at giving CPR, do CPR. If you've never given meds before, maybe it's not a great time to do it right in a code blue when you're just not super familiar with the code medication. So pick a role that you're good at and stick with it, get really good at that. And as you gain more experience, you can go into more of the other roles. There's a lot of things on a code card, but I kind of just wrote on here, and hopefully you guys can see it okay. There's always a defibrillator on there. There's usually pads, suction. You're going to have your recording sheet. There'll be a backboard for CPR that you can put underneath the patient. You're going to have your medications, flushes, IV bag tubing, things to draw up different medications. And then there's usually a sharps container on there as well. But again, every code card's going to be slightly different. Scenarios. We're going to cover really quick a couple different scenarios that you may encounter when you're taking care of patients. We're going to cover like the most common causes and interventions for these things, but we're not going to cover every single possible cause and intervention. I just want to give you kind of the most basic ones that you may encounter as a nurse, the most common ones. So that way, that's probably typically what you're going to be dealing with. Okay. Hypertension. So, in the hospital, patients' blood pressures tend to be high always. Always know your patient's parameters that are acceptable. So if your patient has intracranial hemorrhage, that's what ICH stands for, aka a brain bleed, we typically want the blood pressure to be between 110 and 140. You guys don't need to memorize this right now. I'm just giving you an example of, for different patients, you're going to have different acceptable blood pressure ranges. In a general rule of thumb is anything greater than 180 over 120 is considered an emergency. Blood pressures tend to be higher in the hospital because patients are stressed, they're anxious, they're in pain, they're out of their environment. And sometimes it's just better to treat that with like a PRN medication rather than like start your patient on like a full blown blood pressure regimen. But again, that's up to the provider. We don't usually make that decision. It's important to distinguish when a patient has high blood pressure. Is this an acute or a chronic issue? Some acute causes would be medications, drug use, meth, cocaine. No bueno. Don't do meth and cocaine. Missed blood pressure medications. Like your patient normally takes 8 a.m. metoprolol. They weren't feeling super well. They didn't take it. It's now 2 p.m. They're all admitted on your floor for something. You're like, oh my gosh, their blood pressure is 170 over 90. And they're like, oh, I didn't take my metoprolol this morning. That can sometimes be a common cause. Adrenal and thyroid conditions, and then acute panic, anxiety, or acute pain and anxiety can cause high blood pressure. And we know that your patient doesn't feel well. They're anxious. It's going to shoot their blood pressure up. And if we can kind of manage those issues, your blood pressure should hopefully get better when those issues resolve. Some chronic causes, Smoking, obesity, high sodium diet, lack of exercise, alcohol, aging, genetics, kidney disease, diabetes, obstructive sleep apnea, and heart disease. We know these things, right? These are things that a lot of these, not all of them, but a lot of these are modifiable risk factors. So we can exercise, we can reduce our alcohol intake, we can stop smoking, we can eat a good diet. But of course, at the end of the day, our patients make the decisions that they want to make, and we're just there to support them right where they're at in that moment. So interventions. The patient has high blood pressure. What are we going to do about it? Well, first and foremost, know your cutoff of what you're going to treat versus what you're not going to treat. A lot of patients will just have a PRN, hydralazine or some sort of medication in the hospital to treat like a systolic above 150, 160, really depends. So know your acceptable parameters. And if your patient is outside of those parameters, let's make sure that's an accurate blood pressure. And let's think, why is this happening? Is the patient just anxious? Are they in pain? Should I be treating those things? Or do they have high blood pressure? Did they misdose their medication? Have they been off their home regimen? Another thing is sometimes patients that are super fluid overloaded, they miss dialysis, or they're supposed to be taking diuretics. They've got all that extra fluid in those veins and arteries, and they're nice and juicy, and that causes their blood pressure to be higher. Think of a hose. If the water flow is kind of low, the pressure coming out is not going to be very high. If you crank up that water pressure, that water is going to shoot out, causing a higher blood pressure. And then long term, obviously, we need to educate our patients on, just a better overall healthy lifestyle, healthy diet, exercise, reducing sodium. Hypotension, we're going to move to low blood pressure now. So in the most common thing that you'll see for hypotension for patients is a MAP less than 65. So ideally, we want a MAP greater than 65. Some common causes of low blood pressure are going to be your heart's not pumping efficiently. Your patient may need more fluid. They may need a contractility med. Maybe they don't have enough volume. They had a bunch of blood loss. They had fluid loss. They're dehydrated. They're a trauma patient. Maybe you just gave them a bunch of Lasix and they just peed out 2 liters of fluid and now their blood pressure's low. Sometimes patients, when they're in pain or emotionally stressed, can get low blood pressure from fainting. Too much blood pressure medication, and then also sepsis and infection, low pH can cause low blood pressure as well. Hypotension interventions. First and foremost, the most common thing that we'll do is give fluids. You'll see patients come to the ER. They have a little bit of low blood pressure. We're going to pump them up, give them some extra fluids. If it's a blood loss issue, we are going to give blood products. If we have adequately resuscitated patients with fluids, then we will tend to look at vasopressors like your Levophed, your vasopressin, your phenylephrine, epinephrine, medications to kind of keep that blood pressure up. But first and foremost, we always make sure that your patients are getting adequately fluid resuscitated. And then there are PO medications like midodrine that sometimes patients will be scheduled on if they're just like a chronically low blood pressure patient. Tachypnea. So let's cover tachypnea now. Tachypnea is breathing too fast, anything greater than 20 per the textbook. But of course, every patient is going to have a little bit different picture of what's normal for them. Some common causes are things like fever, pain, anxiety, asthma, infection. Maybe they have an obstruction from like a big mucus plug, anything cardiac related. Or when patients are acidotic, they can be tachypnic because in acidosis, if it's a respiratory problem, maybe their CO2 is really high. So patients will start trying to breathe quickly to blow off that CO2 to normalize their pH. And then I put here, remember when a patient is tachypnic, they're usually compensating for something. So that means if a patient's breathing really fast, we need to look into like, well, why are they breathing fast? Because if they're breathing fast because it's a fever, we want to treat the fever. We don't want to treat them breathing fast, if that makes sense. Now, if they're breathing quickly because maybe they have a lot of junk or mucus in their lungs, maybe they need to get a breathing treatment, then of course that's what we're going to address. But sometimes your tachypnea is actually something else going on, like fever, pain, anxiety. Can be kind of tricky. Some interventions. So if your patient has a fever, we're going to treat the fever. There usually will be a parameter for when you would treat it versus when you wouldn't, like, give Tylenol if your patient's temp's greater than 38.3, 38.4. So that will kind of vary depending on where you work. If it's a pain related issue, let's help take care of their pain, whether that's medication, whether that's getting them moving, maybe a pillow, maybe a reposition. height or ice, heat. You don't have to just always jump to pain medication, which obviously it's there and important if you need it. Anxiety. I put anti-anxiety medications, but typically we don't really start anxiety medications in the hospital. It'll be something that's kind of continued if the patient takes them at home. And then maybe the patient, if it's really bad, then we could do like a PRN or something like that. But typically we don't just jump right into that. I usually try to give patients emotional support. Do they have family? Do they have, do they want to talk about it? If it's an asthma issue, there's breathing treatments available. Infection, we're usually giving antibiotics. And then if a patient has an obstruction, we can go ahead and suction them out. So if they have a lot of mucus filled up in there, maybe they need us to just suction kind of orally. Maybe we need to go down and nasal suction a patient. If they're intubated, we can suction through their breathing tube. Lots of ways we can suction patients. Some interventions. So if this is a cardiac related issue, meaning the heart's not pumping efficiently, so maybe there's backup of fluid into the lungs, then we would need to treat the cardiac issue over the respiratory issue. If a patient is acidotic, we're going to correct that acidosis. Like I said before, acidosis, in a respiratory acidosis, you're going to have elevated CO2. So a lot of times the patient is tachypnic to try to breathe that off. And we don't necessarily want to try to make the tachypnea stop, because if we stop the tachypnea, they're not going to be breathing out that CO2 as quickly. Next, chest x-ray. Sometimes the provider will order that if we can't figure out why the patient's having a hard time breathing. Also, auscultate their lung sounds. Let's go back to the basics of nursing. We should be assessing our patients always, and especially if there's a change, let's reassess and see if we notice a change. If your patient had clear lung sounds and now all of a sudden they're having crackles, that gives us a pretty good indication as to kind of what's going on. Assess their oxygenation ventilation status. Do they need maybe a higher level of oxygen? If they're just on a nasal cannula, do we need to give them a little more support, like a CPAP, BiPAP, or a ventilator? Okay, I know I'm breezing through these things because I had a lot of information in this PowerPoint. We're getting close to our questions. So we have two more sections. We're going to cover bradypnea, hypopnea, and hypoxia. So this would be breathing too slow and a lot of, or too shallow. So anything like less than 12. Sometimes when patients are sleeping, they'll be breathing a little bit slower, but some common causes of breathing too slow that are concerning are your patient got too many sedatives, like we gave too many opioids or benzos, or maybe not we gave them, maybe they took them on their own at home. Patients are alkalotic, or they have some sort of sleep apnea. And I put this question on here: is it associated with decreased oxygenation sats or acidosis? Because that would be a little bit more concerning. If your patient's breathing too slow or too shallow and you see their oxygen is low, definitely immediately want to treat this. Some interventions, and sorry, it's kind of cut off on the bottom. So we have reversal agents. If it's an opioid issue or benzo issue, we have reversal agents on here. This is part of like your ACLS protocol. You'll learn this when you go through like your nursing orientation and stuff like that. But for opioids, we can give Narcan. Everyone kind of heard of Narcan. And with benzos, we have romazicon that can be given. Now, I did put a little note in here. So for your opioid patients, smaller doses and opioid dependent patients to avoid withdrawal, you don't want to just slam a bunch of Narcan on your opioid dependent patients and then all those receptors unbind to the opioids and they're chronically in need of those opioids. So if we just reverse everything, they're going to be in extreme amount of pain. And then with benzos, if we push our romazicon too quickly, seizures can happen. So when in doubt, push it a little bit slower. If your patient is alkalotic, I put bradypnea is expected. And that's because when we have that really high pH, our body wants to start to bring down the pH, and it'll do that by accumulating the CO2. So a lot of times patients will breathe slower if they're alkalotic. If they have central or obstructive sleep apnea, we're going to keep a close eye on their SATs, and they may need a CPAP or something like that to help kind of with that sleep apnea. If I notice a patient with sleep apnea, I'll say, hey, do you wear CPAP at home, or do you know that you have sleep apnea? And I swear 90% of the time they'll be like, oh, yeah, but I never wear that thing. I'm like, we probably should wear that thing. And in worst case scenario, we can always put a patient on BiPAP, or they can get intubated if they're breathing way too slow. Last little section here before our questions, and then we'll go into our Q&A. Hypoxia. So hypoxia is SATs less than 92%. Sometimes your SATs will be lower in your COPD patients or your heart failure patients, and that's to be expected. In your really bad COPD patients, we usually only want their SATs to be like 88, 89, 90s. We don't want them to be at 100%. And if your patient is hypoxic, you check their sats. Let's figure out the cause. Why? Do they need more oxygen? Okay, we can give them more oxygen. Are they taking too shallow of breaths? Sometimes patients are just really uncomfortable. Maybe they just had surgery and they're kind of taking these shallow breaths because they're in pain. And we can encourage them to cough, deep breathe, use their incentive spirometer. Let's treat their pain so that way they can take deep breaths and they're not so uncomfortable. And sometimes patients are hypoxic because they have an obstruction. A mucus plug is, plugging up their airway, and we may need to go in and suction them, encourage them to cough, and deep breathe. All right, some questions. And I want you guys, I think we're going to go to the polls here, or this one might be tricky because this is a select all that apply. I'm sorry, I know. So go ahead and answer in the question box here. But Carly is a brand new med-surg nurse off of orientation, and she comes to you and asks you this question. She says, my patient's blood pressure is 70/45 with a heart rate of 65. She is ANO ×4 and sitting in a chair eating breakfast. So it doesn't seem like anything is wrong. What should I do? Which responses would be appropriate to help Carly troubleshoot select all that apply? So 1, did your patient receive any blood pressure medications recently? Did you double check the blood pressure to ensure it's accurate? What have your patient's blood pressures been trending prior? Did you call a rapid response? How much water did the patient drink with her dinner last night? So go ahead, answer the question. I'll give you guys just a second, and then we'll go over the answer and I'll cover kind of why the answer is what it is. All right, somebody answered A, B, and C. 1, 2, and 3. I like it. Sorry, I know I cut off the letters because you'll see the next slide that I had to cut it off, or else you would see what the correct answer was. So yes, A, B, and C are correct. We're gonna go move on here. Did your patient receive any blood pressure medications recently? This is a great question to ask because sometimes we just need to get rid of, maybe they're taking too much blood pressure medications. When patients are in the hospital, things change quickly, and sometimes they don't need as much, or that they have been receiving. Did you double check the blood pressure to ensure that it's accurate? I've stressed this throughout this whole presentation. Always make sure vital signs are accurate. Don't just go off of one reading. If you get a weird reading, always recheck it. Check it on the other arm. Look where your patient's been trending. Exactly the next answer. What have your patient's blood pressures been trending prior? If this patient had been trending like 90s over 50s and now they're 70s over 40s, I'm going to be like, okay, so they're kind of still on the lower side. Yes, it's a change. Yes, we need to address it, but not as concerning. Whereas if your patient was like 150s over 90s and suddenly they're 70s over 40s, I'm gonna be like, this is not good. Next, did you call rapid response? This is not the answer because we need to troubleshoot first. We need to look at the information that we have, make sure it's accurate before we just go ahead and call a rapid response. This patient's sitting in a chair, they're alert and oriented, they're eating, they're talking. Let's just look at the patient first and think, is this a critical situation? And then how much water did the patient drink with dinner last night? That's just a filler. That's not important. Mr. Ham, let's go to the next question and I want you guys to answer it. Mr. Ham is an 80-year-old male with a witty sense of humor, admitted, not administered, for a hip fracture post-ground level fall. You two have been joking around, teasing each other all shift long. Before shift change at 1900, you go in to say goodbye to Mr. Ham and see if he has any last minute needs or requests before you leave. Upon entering the room, you notice that Mr. Ham has an upward gaze and is drooling. You're unable to get any verbal response from him. You call for extra set of hands, check his vitals. Blood pressure is 157 or over 81. His heart rate's 101. Oxygen sats are 92 on room air. His respiratory rate is 8. And then his temp is 37. So which of the following interventions is the least important? So this is the least important intervention. Obtain a stat ABG. See if the patient has received any recent narcotics. Administer the patient's scheduled 2800 PO metoprolol early. Take the patient to a stat head CT. I think this one is over on the poll. Yeah, it is. So you guys can go over to the poll section, the little graph looking thing, and answer it there. Because this one is not a select all that apply. Or you can answer it in the chat too. That's totally fine. I'm down for whatever. All right, lots of C's on there. Yes, C is the correct answer. So administering his PO metoprolol early, not really a priority. He's sitting there with a change of mentation. He's drooling. Those are not good signs in general to administer PO medications. But two, it's just not the most important thing. Even though his blood pressure is a little bit higher, 157/81, we have bigger issues going on. So obtaining an ABG may be appropriate to figure out why he's so altered. So let's see if the patient just got too many narcotics. If he had any recent narcotics, that would be a valid thing to check. And then taking the patient to a stat head CT. This would of course be ordered by a provider, but something that we could definitely do. Potentially Mr. Ham's having a stroke. I don't know. Joseph is an 89-year-old patient admitted to your telemetry floor for new onset AFib and pneumonia. At lunchtime, you hear the cardiac monitor alarm and note that Joseph's O2 saturations are not picking up and his heart rate's 134. You walk into the room to see Joseph slumped over in bed, pale, and taking very shallow breaths. You check for a pulse and feel a weak pulse. You call for help. Meanwhile, what would your priority intervention be? And you can answer it in the poll or answer in the chat. Check his blood sugar, start CPR, oral suction the patient, administer breath via bag valve mask. So what is our priority going to be? What is the most important thing in this situation? Looks like we're getting some answers over on the poll. I'll give you guys one more second here. This is our last question, by the way, and we're moving into the Q&A. Thanks for bearing with me. I know this is a lot of information. All right, lots of answers on the poll. So yes, correct answer is D, administer breath via valve mask. So are we going to check his blood sugar? Potentially, that would be a great thing to do, but is it our most important thing? No, the patient's not breathing very well. We need to help him breathe for him. And that's what I covered in our critical thinking pearls. If your patient, circulation, airway, breathing. If we're having issues with breathing, having issues with circulation or airway, always more important than blood sugars or anything else like that. Of course, we do want to check a blood sugar, but that's not our first intervention. Start CPR. He has a pulse. We don't need to start CPR. Someone has a pulse. Oral suction the patient. We potentially may need an oral suction, and maybe he does have something in there, but we can't gather that information from the question here. And so that's not going to be our priority. Our priority is going to be to administer breaths via bag valve mask. So, okay, I am going to open up for you guys for questions. You can ask them in the chat. There's also some over in the Q&A bank that I will go answer. But if you want to follow me on social media, it's just my name, Ashley Adkins, for Instagram and TikTok. I post a ton of educational content on there. And then I do have a couple nursing crash courses. So this information is actually from my critical thinking crash course. And I go a lot more in depth. It's a lot more not as crammed into such a tiny amount of time. And there's a lot more information on there if you are interested in that. And I have other crash courses as well for new nurses and all that. But and if you have any questions for me, you can reach out to me on social media or my email. I didn't put my email here, but it's ashley.adkins at gmail.com. So I'm going to go ahead and answer some of these questions here that are in the question box. The top one is, how do you answer exam questions without adding more information to the question? Isn't that how you critically think? So I'm going to assume this is kind of talking about the NCLEX or maybe for exams. It's really important that when we're looking at a question, we only look at the information that is given for that question. It's kind of tricky because this is a little bit different than like the real world of nursing, but isn't that like everything in nursing school, teaching you, to take the test versus teaching you the real world? If you start finding yourself saying, but what if this, but what if that, or, but if this is going on instead of this, you're thinking too much into it. We need to just look at the information ahead. And if you start to find yourself going down that path of like, well, what if this? Probably not going to be the correct answer, because we just need to use the information that we're given on test to, address the question. You start looking into it. Like we could do the same thing for our question back here, about Joseph. He slumped over, not taking great breaths. If we said, well, maybe his blood sugar is low. Well, that's not our priority here. Oops. Sorry. Okay. Next question. What strategies or approaches do you recommend for nursing students to effectively learn and apply nursing diagnosis in clinical practice, and how can students develop their critical thinking skills in this context? So we can practice critical thinking without actually being at the bedside by doing scenario types questions, which is kind of what I was showing you here. And I think that critical thinking skills develop definitely over time. So don't feel ashamed if, like, when you're in clinicals or you start off as a new nurse, you're like, well, I don't quite know exactly what's going on here. But strategies or approaches to effectively learn and apply nursing diagnosis and clinical practice, I just recommend practicing at home, looking up situationally based questions. I know Picmonic has a lot of great questions, and practicing in like a case study basis versus, obviously the bedside is the best to practice at. But always looking into, well, what if this happens? What am I going to do? When I started off in the ICU, I remember asking my preceptor, like, well, what if both my patients code at the same time? And she's like, I mean, I've never personally had that happen, but she'll gather some help. But I used to always think, okay, if my patient stops breathing now, what am I going to do? If my patient loses their pulse now, what am I going to do? If I walk in and I see this, what am I going to do? And you can start doing that yourself while you're in nursing clinicals and by practicing other questions. I like this question. Any tips on balancing mom life and nursing school? So I did not have my kids personally in nursing school, but I did. I do have 2 kids now, and I am a nurse. And I think that, I don't know how many of you have kids here, but if you do, you could probably attest. You're always trying to figure it out. You're always trying to find that balance. And I don't think we quite ever figure it out. We just do the best job that we can to be in school and take care of our kids, or work as a nurse and take care of our kids. And you just get through it. And if you have help and resources to help you watch your kids, making sure you're taking time for yourself and your mental health and taking breaks. Nursing school is important, of course. The end goal is to become a nurse. But if you're truly struggling finding that balance, it's okay to take a step back and evaluate, like, okay, what are my priorities right now? You always need to take care of yourself first. Let's see in the chat over here. Someone said, I love your heatless curls. Thanks. I'm on a heatless curl trend over on my social media. So if you, it's fun. Can you please clarify if CAB instead of ABC? I'm still learning ABC in nursing school at the moment. Of course, it'd be helpful to know which is preferred on the NCLEX. I'm going to be totally honest with you guys. I am not like an NCLEX style guru master as far as like which questions the NCLEX prefers, information the NCLEX prefers over another. So I'm not going to be the best person to answer this question. I personally hear both thrown around, CAB, ABC. If in nursing school they're still teaching you ABC, then that's probably going to be what is most driven on the NCLEX. And of course, you have to look at that. However, in my opinion, they're kind of all important. If your patient is not circulating, of course you're going to address that. If they're not breathing, of course you're going to address that. I don't think it matters if it's CAB, BAC, ABC. But for your nursing program, if they're teaching you ABC, and that's probably most likely what they're going to be teaching on the NCLEX. Ask me some more questions in the chat. Whatever you guys want to ask, or ask away on the Q&A. If you had anything you wanted to go back into, we have a couple more minutes here. I know I flew through all of this information. So, thank you. You're welcome, Emily. Sorry, that was kind of an answer, but not an answer for things. And I wanted to make sure I would just got through to this Q&A. We use up this time because I know I blew through our presentation pretty quickly, and that was a lot of information. Will you be sharing your slides? Marissa's going to know that answer, but I believe all of this will be available. This is all recorded and will be available for people to go back and access. I just don't know where, and I'm sure Marissa or someone from the Picmonic team is going to have that information as far as going back to this information. Because yes, I know this was a ton of information, and you probably didn't have time to scribble and write down every single thing I was saying.
Yeah, that is absolutely correct. So we will be sharing the recordings out in 24 hours. So you'll be able to access the slides again through the recorded session. So just look out for your email to see all of the sessions. They'll be linked directly to which one you're looking for.
Yes. Thank you. You guys are welcome. any more questions for me about anything? Nursing school, ICU life, mom life. I try to provide a lot of great free resources for you guys over on my social media, whether you're a nursing student or you're a new grad nurse. You guys are funny with the heatless curls. You're cracking me up. I'm on a hair health journey over here, guys, okay? Trying to, we're just trying to do it all, aren't we? Let's see. How did I get the idea to start making nursing courses? Love you and your content, by the way. Thank you. I have done nursing education for a really long time, and I have been working kind of just a little bit for other educators. And then I realized like I could do this on my own. And I just felt like there's such a gap between like the nursing school education and then like the real world education. Like, of course, there's textbook things that we have to follow and policies we have to follow. But like, there's also this is the down and dirty real side of nursing. And so for my nursing crash courses, that's what I try to kind of tap into both worlds. I want to give you the evidence-based education side of things, but I also want to give you like, well, but here's the real deal. Like, this is how it is in the real world. This is what you're actually going to see. And so I give a lot of that information and I do have a lot of questions in there to help practice scenarios and things like that. I'm not an NCLEX style. What do I want to say? Like, I wouldn't say to take my course in order to pass the NCLEX, because it's not necessarily for the NCLEX. Will there be overlapping information? Of course. But it's more so, this is the real world of nursing and what you need to know as a bedside nurse, as someone who still works at the bedside. And I see a lot of things. I see a lot of nursing students. I see a lot of new grads, and these are the things that they seem to struggle with when they're starting off. Okay, there's a couple more questions here. Do you have any advice for a new grad CVICU nurse who is currently on an RN BSN program? First and foremost, being a new grad in the CVICU, amazing. Like, congrats to yourself. If I had any advice, it's use your resources around you. I think that new grad nurses in the ICU can go one of two ways. They either like thrive and do super well, or it's really hard. And that's kind of nursing in general, no matter what area you start in. But use the resources around you. You're never going to be alone. Always ask questions. And then learn. It's going to be information overload when you start off with, but I used to write down, things that I wanted to look up when I got home. So that way, when I got home, I would look things up. Now I have that information for my next shift when I go back. Dude, the gap in information that you have to learn when you first start off with is massive. Like, there's so much, but you're going to start kind of piecing away, learning information, building more information on top of that, and kind of creating your foundation. If I can give you one great piece of advice, it's the basics are important. Don't neglect all your basic nursing care. We can get carried away in the ICU with like, we've got all these drips and ventilators and crazy adrenaline and things going on. But at the end of the day, your patient's human. They have family members that are human. Do the basic care, oral care, turns, peri care, just making sure your patient is getting all those basics so they don't get another infection. They don't get another problem while they're in the ICU. And answer like two more questions here really quick. Do you have any recommendations on where to start in our nursing career? Do you believe there is a particular specialty you should start in? No, I think that one, you should apply to wherever you want to apply to when you start off as, when you graduate nursing school. It's, if you love labor and delivery nursing and you want to be a labor and delivery nurse, I would never tell you, don't start in labor delivery. You have to go to med surg. If you get the opportunity to go to labor and delivery, I couldn't say I would ever turn down that opportunity. So, if you get that chance, take it. However, if you just don't really care where you start off in, med surg and telemetry are a great just core basis foundation to start off in. That'll give you a good set of skills to transition to whatever area you want. And you'll see a lot of things in those areas to kind of determine, do I like psych? Do I like labor and delivery? Do I like ER? Do I like ICU? Last question here. Do you recommend being an active member of nursing organizations while being in nursing school? Any specific ones? And I'm not sure which fields I want to work in yet. I think being active in any organization is wonderful when you're in nursing school, just so that way when you do graduate, you can put it on your resume, you can bring it up in your interview, like, hey, I'm an active member in this organization. I would look at what you're interested in. So there are organizations for like your nursing school, but if you are interested in like critical care nursing, you can go to the ACCN. If you're interested in like labor and delivery, there's organizations for that specific group. So take a look and see. Usually have to pay a slight fee to join, but there's lots of continuing education opportunities and things that you can like put on your resume. So if you have any more questions for me, I'm sorry I didn't get to all of this, all of your questions. Reach out to me on social media or email me, and just put in there that you were part of this summit seminar, so that way I know where you came from, because I get a lot of messages and I try to get back to the ones that are like kind of priority. So I will prioritize your guys' messages. But thank you. I know that was so much information, and I just probably contributed to your information overload, but I'm happy to answer anything or break it down further for you. Just we're out of time here. So I appreciate you guys joining in, and happy Sunday. Enjoy the rest of your seminar.
Ashley, thank you so much. To answer this question really quickly, the recordings are not time sensitive. If you registered for the event, you will get them in an email and you'll have full access to whenever you need them. So that should about wrap up this session. I want to say thank you so much again for being with us today. If you have more questions, you can send them out to Ashley. She gave her information, but also you can reach out to webinars@truelearn.com. And we hope to see you at our next session starting promptly at 12 p.m. ET with Morgan Lima, as she shares tips to landing skill boosting jobs that pave your path to your career success. Thank you guys so much.
Yay. Bye. Have a great day.